So I am first going to start off with difficult cases. Because you invariably, when we talk of femto, people turn on and tell us it doesn't work on a hard cataract, it doesn't work on a hard brown, it doesn't work on soft, it doesn't work on a pediatric. Let me show you that it really works on all of them. Not only that, it works well. Let us first take a rock hard cataract with a femto. As you are well aware, with a rock hard cataract, doing even routine cataracts is comparatively difficult. But if you take a lens which is so hard that you would look at it and say even doing phaco is going to kill us, is a true test of the procedure. What you need to do with all the femtos, just as a quick introduction, is you have to center a small little device on the eye which acts like a linking or a block system, and then subsequently you evaluate it on a screen by which you can work out exactly what you want it to do. When we take rock hard cataracts, we try to make sure it has a sufficient number of repetitions and that the intensity of the ultrasound of the femto cataract generated is adequate. Once that is enough, then you usually can get away fairly easily. It takes just the same length of time as it does, usually anywhere between 40 seconds to a minute to finish the procedure, and after that you just flip the patient out. Now this is exactly how it looks subsequently afterwards. As you notice, it's a very hard brown cataract. Big advantage of femto is that the rhexis is always perfect. In a very hard cataract, if your rhexis is not up to the mark, you are in solid difficulty. Here there's really no difficulty. We settle it down and then we simply rotate the lens completely. Notice the little clefts which have already been formed there. What I will want you to notice is when we are doing the procedure, the amount of ultrasound energy we use is really very low. And we utilize the clefts which have been created by the femto cataract to literally split it into little bits. Where the original cleft would have been greatly difficult, here as you notice, little clefts simply break apart and go. So even when you have a rock hard cataract with negligible ultrasound energy, and that also on a pulse mode, you can manage to handle really hard cataracts comparatively easily. Common sense therefore dictates that the endothelium naturally is hardly affected by the amount of energy used, with the result that you can get away and do a pretty good procedure and a surgery without difficulty. And subsequently I am implanting a trifocal lens, which is one of my current favorites. And that is how it runs. As you notice, being a very hard cataract, there was hardly any capsule worth talking about. So we really haven't even bothered about it. Let's get out and see something a little different. Quickly taking, though pediatric cataracts will also be taken by Dr. Vasavada, who does a large number of them, I just want to show you how simple it is to handle it. This is a little child. He is 8 years old. All these cases nowadays we do routinely we give them a little bit of sedation. That's the anesthetist's hand supporting their head because the child is sedated. And then we routinely take them in and we put them under the femto. One very big advantage of the femto is that you are always certain of getting a perfect rhexis. Once you get a great rhexis on a child, literally the surgery becomes a joke. And not only that, you are assured of getting a good lens in the eye. You notice a congenital cataract, notice the nuclear lens which was there in the middle. And subsequently after that, the procedure takes hardly 12 to 15 seconds to clear up. Interesting part is what you see immediately afterwards. Okay, we take the child out and we slip it out, really not much of a hassle, difficulty, and we flip it out. This is the catalyst system which we are working on, which really works like a dream. And usually in these children, the one big advantage is the fact that you can get a perfect rhexis. With a great rhexis, your surgery automatically becomes great, and you can assure the family and whoever comes along, including the persons who are watching, that you will get a great show. Here simple aspiration is enough in a child. It just whistles off, as one would say. You do a little bit of aspiration and you can put in your put in your lens subsequently with no great difficulty. Just be careful in a child if you do it with a femto to keep enough place behind, because the capsules are very low and you do have to adjust your femto to be sure to get it done. As routine, I prefer to use a multifocal in all little children. Children adapt to multifocality almost immediately. I've been doing it for many, many years. I've never been unhappy. There's children who have done, maybe what is it now, close to about 18, 20 years ago, have now become adults and really are happy with this. But just to reposition what I'm trying to say, that this is really the way to go. This is a toric lens. I'm using a Zeiss markerless system which projects onto my scope the axis which I want and where I want to rotate it, so I can then get a perfect positioning of the implant inside the eye. The markerless system really works well. I'm quite happy with it. One big advantage is the head moves, the system moves with it once the recognition marks are done. So it really works very nicely. Having said that, let me get out and take you on to something a little more interesting. I'm going to take you on how you work with a subluxated lens. They say that a subluxated lens should never be handled with a femtocataract. Let me show you the difference it makes with this procedure and enables you to do a procedure which really would be difficult or almost impossible to do. Last year, Dr. Ganesh had shown us a beautiful one. Mine doesn't come in his class, but it comes close. Similarly, you attach the interface on, swing the patient underneath, and what you are now trying to do is position it in a manner in which the subluxated lens can be operated and worked upon. So a good amount of what you are going to see just now is the changes which we make when you look in. Once the integral guidance system does it, I want you to now notice the lens. Notice the lens which is tilted at the bottom. That was a warning message which the machine automatically gives. And you now need to reposition these markers to your dislocated lens. So you have to literally, because the instrument can no longer gauge it for you. And if you notice the lens which is subluxated, you have to mark it in a manner so that the instrument can then recognize where the lens precisely is, both in the front part of the lens as well as subsequently in the back part of the lens. This is the only critical part, and if you have a good technician, which fortunately I have, it makes life very easy. He can do all this for you, and literally it is done in minutes, so it does not in any way affect your flow of work. Notice the lens. Your setting has been done. You have to set up the iris to the points because it has to identify the edge of the iris when it works also. And then subsequently, because it is dislocated, you move the point at which you want the rexus to be done precisely where you want it. As you can see, you cannot get a more subluxated lens, and then subsequently you just set your settings to the level at 700, which gives you the safety margins at the back part of the eye, and you proceed. Doing the femto is of course fairly simple. It really doesn't take any difficulty or any problems. And this would be a case which would literally have great difficulty in doing a rexus. But the advantage of doing it with the femto is that your rexus is perfect. And once your rexus is perfect, then handling these cases becomes simple itself. Notice the subluxated lens. Notice the beautifully placed rexus in the middle. There's really no difficulty. You need to make your side ports. I usually utilize, and in these sort of cases, I like to make my additional ports just in case when I need to put in my hooks to do it. Doing 3 ports with a phaco is easy. Doing 6 ports with a phaco is not recommended with a femto phaco. So here we have got the edges of the rexus. We notice the rexus literally floats off. So that's your rexus which is done. We put in the hooks and we anchor the capsule into place. in all four planes so that your subluxated lens is supported. Literally standard operating procedures, as I would call it. Once that is done, then you open up the incision which you had made, and we use a ring. I normally utilize a loader which enables me to put the ring in easily. Before the ring is put in, I like to aspirate out. Since a lot of these cataracts are soft, now that you have supported it, simple aspiration just eliminates it. What we do here is we don't use a positive aspiration, we just pull out the aspiration line, so the flow of liquid inside the eye is more than adequate then to help you out. At this point, we inject in the ring to stabilize the capsular bag. Always better on the inner side where you are injecting the ring to release the hooks at that place, because otherwise what happens is the ring gets stuck at the edge of the hook and it makes life very untidy. As far as possible, try to always use in these sort of cases a lens which has a Rayner type loops. This is a multifocal which has been designed by Care Group, which makes a very good trifocal lens, which we are now flipping into place. You can notice the multifocal rings which are there on the surface. You remove it and the procedure is over. Literally, you have done a major surgery by using this femto. So in many ways, femto is the answer. It is the way to go. It is going to revolutionize surgery as time gets on. And you have people who tell you it is not a functional concept. Don't listen to it. It works great. I do a volume surgery, and femto does not in any way detract from the time which I utilize.